Hi, everyone, and welcome to the NAMI Santa Clara County's September general meeting. We're going to start in just about a minute. I'm just trying to go live on YouTube, so I'll see if that has worked or not. It's working. Okay, so I see that people are still joining in, so we'll wait maybe a minute and we'll get started. All right. Okay. So welcome everyone to the NAMI Santa Clara County September general meeting. Before we start the meeting itself, I'm going to go ahead and give some updates from NAMI Santa Clara County. So all our programs have been virtual since shelter in place. That was last year, March of 2020. It's been such a long time. The warm line is up and running from 10 a.m. to 6 p.m. Monday through Friday via phone as well as email. And we also have our family support after hours. It's available on evenings and weekends. All support groups are listed on our website. Our website is www.namisantaclara.org. And the support groups are offered over Zoom. The educational classes. So for all the educational classes, such as family to family and familiar to familiar, persona to persona, peer to peer, provider education, you can contact our warm line number, which is 408-453-0400, and select option number 1. Just to give you a little bit of more information, because our schedules keep changing, but provider to provider class starts actually October 22nd. The peer-to-peer class starts this week, family to family class mid-September, and the next class will be in January. NAMI Basics is on demand and on our website, and you can take it at your own pace. Same with NAMI Homefront. The next FaithNet training is on September 23rd at 11 a.m. The community peer program, we continue to do the matches by hospitals as well as self-referrals. So do check our website for more information. Again, it's www.namisantaclara.org. We also update our blog section with new articles written by Maureen Milo. I also want to make an announcement about NAMI Walks. NAMI Walks Silicon Valley is on October 9th. It's a virtual event, and we have a lot of fun activities planned for you for the virtual event itself. Our chairperson for this year are Senator Dave Curtisi, Congressman Ro Khanna, and Dr. Sarah Cody. Our keynote speaker for the NAMI Walk Silicon Valley is San Francisco 49ers offensive lineman Laken Tomlinson. This year, our goal is $230,000, and NAMI Walk Silicon Valley is our biggest fundraiser and an event where you can advocate for individuals and families with mental health issues. For more details on the NAMI Walks, you can visit our website, which is www.namiwalksevents Silicon Valley. Actually, there's a / in between. So www.namiwalks / events Silicon Valley. I was just going to mention that we also have a rally call coming up for team captains or anyone who wishes to register, which is on September 22nd at 6 p.m. So feel free to send me an email. I will put my email in the chat box in a bit, and feel free to send me an email, and I'll be happy to share the link to register for the rally call. During the rally call, you can learn more about how we are going to have the virtual walk and how to fundraise and how to build your team and all the fun activities that we have planned for you and amazing gifts that you can win. Now that I have given you the updates about what's going on at NAMI Santa Clara County, I would like to introduce our speaker for tonight, Dr. Kalpana Nathan. Our topic tonight is mental illness and substance abuse in the time of COVID. A little bit about Dr. Kalpana Nathan. Dr. Nathan is a Chief Medical Director at El Camino Hospital's Scribner Center Mental Health and Addiction Services. She's both certified in general adult psychiatry, addiction psychiatry, and forensic psychiatry. She's also an adjunct clinical professor in the Department of Psychiatry and Behavioral Sciences at Stanford University. Her interests include meditation, global mental health, and promoting wellness for all. Welcome, Dr. Nathan. Over to you.
Thank you so much for the kind introduction. It's an honor and a privilege for me to be here today. For talking to a group and supporting NAMI, such a great organization. I have a lot of slides, so I'm going to go directly into that, and so that I cover the topics. I've tried to divide them into three main groups. First, I'm going to talk about mental health and substance use, and then the impact of COVID, and then the last section will be questions and discussion. There were several questions sent to me earlier. Appreciate you taking the time to do that. And we'll go over that and also open up for more discussion and questions. Sorry, I'm trying to move so I can see my slides. All right. We don't have any data yet from the impact of COVID, although there are some data coming out. The major ones like SAMHSA, or the National Survey on Drug Use and Health. The latest is still only 2019. So this goes back. So it'll be very interesting to see what's happened in the last couple of years, 2020 and 2000, also the current year. So here, if you look at the total number of people, it's 61.2 million Americans who have either a diagnosis of mental illness or a substance use disorder. So the overlap right in the middle, it's kind of like the Venn diagram. So it's a 3.8% or 9.5 million. So people 18 or older who have both an SUD, a substance use disorder, and a mental illness. So 51.5 million people who have mental illness and about 19.3 with any kind of substance use. And if the middle group, when you look at it, is the 9.5, that's the co-occurring dual disorders when people have both mental illness and substance use disorder, and that's a 9.5 million. And of that, 3.6 million have a co-occurring SUD or substance use disorder and a serious mental illness. So the lifetime prevalence of a mental health disorder with a coexisting substance use is greater than 40%. And if you look at it, the treatment is still, although we've talked about co-occurring disorders for a very long time, you can see that only about 48.6% received either mental health or addiction treatment, 38.7% received only mental health services, and only 7.8% received both mental health and addiction services. And when you think about dual disorders, they really coexist. It really sort of, in my mind at least, it doesn't matter what might initiate the other. They both are sort of primary, and you want to treat them both simultaneously. Many years ago, people kind of will sort of do sequential treatment. They'll say, you have to take care of this first, and only then we can treat that. Even to this day, there are some places that say that, but it really is very difficult to do sequential treatment like that, and you really want to treat them both together. And you have a variety of treatment options, pharmacological, psychosocial, and behavioral interventions. I wanted to talk a little bit about understanding addiction. In my mind, we've talked a lot about the reward pathway. So I think about more the biological aspects of addiction. For me, addiction is also a very treatable illness, the way I look at it. There is quite a bit more stigma for addiction. It's hard to say with mental health and addiction. I think it seems that there's a little bit more stigma. So understanding addiction from a biological perspective takes that away, rather than blaming somebody who ends up using substances. I think it really doesn't matter how it began or what were the circumstances. It very quickly gets out of control, and it can happen to anyone. So that is sort of the way to think about it. And Koob is a researcher who's done a lot of work. I like his diagrams are always kind of fun to look at. It very simple. In the past, it's a lot of emphasis on the reward pathway, that we are, as human beings, we want pleasurable things, and we seek for the binge or intoxication, the pleasurable pathways, and how we access reward pathway was what was talked about, for decades. The little bit more recently, I think, at least Koob's, I think for some years now, this whole idea that's not just the positive, you're not just looking to get the high or the pleasurable effects of the substances, but you're also trying to relieve the negative state you're in. So the negative state is a very interesting state. It could also be in a withdrawal state, or people who are very anxious and depressed, and that's where the genetics, the epigenetics, also the we kind of think about an allostatic load. It's your cumulative stress, and when it gets so difficult for people, they're not necessarily looking to just get that high. Often the high is not really there, very, very little at least, towards once you're in that cycle, just to relieve that negative state. And both are equally powerful states to understand. And there is an interesting word, hyperketophia, that explains that. I think that's, anyway, it's a Greek word, and I kind of, it makes you understand exactly how people are caught in this cycle. It's a vicious cycle, and important to remember that it can happen to anyone, and no one really chooses to kind of get caught in there. It sort of happens. So having said that, going back to this slide, that's the 3-stage cycle. There's the binge, intoxication, and withdrawal, the negative effect, and the preoccupation and anticipation. And the craving happens despite you knowing there are so many negative things that have happened. You know this is not a good thing for you. So it's overriding, and the intensity or the repetitive nature of a drug. Certain substances have a very high degree of the craving that we experience. So again, to understand it from that perspective allows us to think about addiction in a different way. Addiction also is a field all of us have been affected by in some, either with family or friends, or it's so prevalent. People have very strong personal opinions about it, and which is okay. But I think if you understand it from this perspective, you're able to view it and address it differently. I hope that kind of makes sense. So in the discussion, I wanted to put that up front to give an overall impression on how we think about addiction and how we talk about it. And this is another thing about, again, from Koob, it's an older slide where he talks about this impulse. So there's the impulsivity that runs. There's also a compulsive, you're kind of caught in that. There's a repetitive behavior, almost like it's not OCD clearly, but it's you're caught in that cycle. And those are two very different aspects. So there are some people who are impulsive and can't kind of, control that urge to give in to that urge, but there's also this other cycle that's happening. All right, some of the things that play a role in considering, how does one start? I heard this a long time ago, someone talked about the agent, host, and environment, and I still kind of think of it along those lines. It's everyone has sort of a drug of choice, if you will, our personalities or what kind of brings us relief. There are some people, prefer stimulants, some are more sedating things or whatever it might be. And then the substances that are available, the environment, the society. Well, today in the US, although opioid crisis is talked about a lot, here on the West Coast, it's predominantly amphetamine. Methamphetamine is what we see a lot of. Thankfully, we don't see as much of opioids, which is still going on in the rest of the country. But amphetamine use, if you look at the opioid crisis, amphetamine also causes death. People often underestimate the lasting impact that amphetamine can have on the body and how much it affects the whole, the mind and the body. The other things are what's readily available. I always say the number one, legal versus illegal really doesn't make a big difference to me. The number 1 and 2 killers are nicotine and alcohol, which are readily available everywhere. And those are, if you want to do a 1-minute spiel for when people are in pre-contemplation, when you're not quite ready to say whether I'm going to stop or not, I usually see, I'd say 450,000 people die each year from cigarette smoking, 150,000 people from alcohol, and, something like that. And you want to give like something that's immediate benefit when people stop using, you could smell things better, you could save money for smoking cessation. I try not to say it'll take 30 years for your lungs to clear up and, there are benefits to, you do breathe better and, something like that. And if you were to make even a little 1-minute spiel like that, they say physicians, even if people may think about it right away, people don't change, but 3 or 4 months down the road, they may say, okay, maybe I want to give it a try. So the process of shifting and changing as we, as human beings, I think it's very difficult. As I've gotten older, it's very difficult for us to change our behaviors, I think. It takes a while for us to mull over things and decide. And that is great progress. If I were to change from pre-contemplation to contemplation and say, hey, this is something I want to work on, once I've owned it, then I am going to do something about it. Even then I can put it on a back burner and say I have other things going on in my life. But once I own it, that's a huge shift. So being also happy with the shifts we make along the way, rather than thinking today I have to go from this to that place. So again, availability, what do we see? These are sort of learned behaviors. If it's readily available at home, if you come home and your parents kind of, after a difficult day, they say, oh, I do need my glass of wine now. It's a way to relax, or what you see and what society says. So those are all sort of the beliefs about it, or the knowledge. The gateway drugs is something we talk about a lot. And in fact, even smoking, earlier you start, I worked in San Francisco General Hospital years ago, but in a methadone clinic, and most of the people who got dependent at that level, when you have injection drug use, they started like in, like 8, 9, 10 years old. So the earlier you start, it's going to have the trajectory and very quickly kind of moves along to other substances. I think what might prevent or reduce, I think it's really open discussions about substances in community, in schools, at home. And I'll talk a little bit more about, other skills that we can use. It's these days, there's so much data out there. And of course, I would talk a little bit about cannabis, because that's a question that comes up a lot. And everyone would say, it's always to me, like if I'm trying to get someone to take something like, citalopram, which has been around forever, like SSRIs, gone through all these, and then people would say no, but that's, I don't want to trust that, but this is pure, I can get this from the store and I know exactly what's in it. You actually don't know what is in it. Much as we think about it, the regulations, it's an unregulated thing. So how much you cut per thing, exactly not, one day you may get something else, or other contaminants are often there. So understanding what it is you're getting. And it's difficult to kind of talk about, I do have a slide on cannabis, so I won't derail now, I'll come back to it. I'm thinking about relapse prevention once you stop. So there's the detoxification. I have a lot of respect for AA and 12-step. It's an amazing organization. Again, a lot of the data about treatment for addiction comes from AA, and people, if they stop, it's one day at a time, but in actually a year of taking good care of yourself, taking your medications, treating your eating well, your nutrition, you sleep well, you actually get better. The greatest risk for relapse is in the first 3 months when your body is adjusting and you stop. And then again, I think about 6, 7, 8 months as a small group, but predominantly if you make it past a year, the chances of doing well are very, very good. And in terms of relapse prevention, for me, it's always, I usually say abstinence is always the goal. It's very different. Harm reduction is reducing harm to yourself, to others, but abstinence is always the goal. And that's a biological reason. Once your brain has been primed for a substance, there's really no going back. And, you've kind of, the loss of control is what addiction is. It's difficult to go back and say, I'll just have only one glass of wine now. And I used to have a lot. It very quickly goes down that pathway. And that is really why I think the abstinence is the goal. But our job is to meet people wherever they're at. If you're in pre-contemplation, we do education. If you're in, so they're each level, wherever you are, our job is to sort of engage people and have that discussion. And medication-assisted treatment, I do want to talk a little bit about it. It is, there's lots of data now for naltrexone for alcohol use disorder. We don't really promote it as much. Santa Clara County, I think, has gotten lots of, and San Mateo as well, has gotten money from the government. SAMHSA has promoted it a lot. So you do get in the county, the naltrexone injection is available, so people can get that monthly injection about 6 months or so. And they are engaging in treatment or AA or wherever they are going for support. The chances of recovery are very, very good. And this is coming back to, again, a little bit about cannabis. If you look at, this is again, SAMHSA data going back to 2017, it's about 15%, much higher than other substances. And if you're using, so here it is about, if you've never really used any marijuana, your chances of doing opioid is, as you see in the slide. So someone who's also using cannabis, so greater chance of you using other substances. So it puts you at risk for going on to use other things, and also greater chance with MDE is the major depressive episode. And this is a question that comes up a lot, maybe even about, I would say maybe 6, 7, or even a decade ago. I was not one who believed that cannabis caused any psychosis. I think it really wasn't, although that discussion has gone on for a very long time with psychosis. There are twin studies, there's lots of data. Some people believe that cannabis, because there's a huge, I think it's 70 to 80% of the people with psychosis could have had some use of that. So that's been an ongoing discussion. And in general, I didn't think, it might make people somewhat slightly paranoid, but not really psychosis. However, I've changed that, meaning I think differently now because of the potency that's available there. People can be very, very psychotic having used only cannabis. Again, I think when you use cannabis, it also has lots of other things that are in it. And I have another slide. There are new psychoactive substances. There's a whole range of substances that are they're called illegal highs. You can get them on an app, and you can get them any different ways. In fact, the opioid crisis is because of the fentanyl analog. It's like it's a legal thing that you can bring in, and large quantities are readily available because you can't, it's not illegal to be transporting certain things which are not really just fentanyl. I hope that makes sense. So then, because of that, there are so many other substances and contaminants that we don't even know what's being used. But regardless, I would say just cannabis. There are people who say they grow it and they only use theirs. So still you see people getting really psychotic symptoms with it. The other thing with cannabis, it stays in your body for a very long time. So it's lipophilic, or gets into your fat cells. So it's 30 plus days that's in your system. I think also that's not anytime any substance stays for a very long time in your body. It's a good thing to take something that kind of gets out very quickly. I think, it has to clear out of your body. It stays for a very long time. And then if you're cumulatively adding, ingesting daily, most people are using it daily, and then the levels, so you can imagine the levels are really very, very high. I used to be a medical review officer, where you look at people's in another job, but you look at people, employees who have drug screens, and you can get kind of levels. You have to kind of talk to people. So this has been even maybe more than a decade ago, the levels of cannabis in people's system can be very high because of this issue of smoking daily and this cumulative impact. And I think it's very difficult to say, but I think when you say it either initiates and maintains, there are two aspects. So a substance can initiate and then you can maintain the psychosis or psychotic symptoms. However, amphetamine, I think, is somewhat unique in that once you've used, even if you didn't, I think there was an article that came out a few decades ago about someone who stops using amphetamine, and months later, psychosis begins. So I think amphetamine is one that just really alters, and probably the most, of all the things that can affect your brain, your mind, in a significantly long, prolonged manner, I would say amphetamine falls under that. And the psychosis that also comes from that, usually I don't believe, again, we can have a discussion, really doesn't respond very well to antipsychotics, and they persist. Those symptoms can persist for a very, very long time. And one other slide about cannabis, I'm going to talk about some short-term effects. The interesting thing about cannabis, it increases your heart rate. So you think you're relaxed and sort of laid back, but really your heart rate is kind of going really fast. So you misread certain cues. So there's more interpartner violence, the paranoia. So there's this your whole system is sort of revved up in a way, which is odd. And hence there's no respiratory depression, or unlike a downer. So there's a different kind of a set of symptoms you see. Now, the other interesting thing about cannabis is there's the hyperemesis syndrome. I've seen this often, although you're supposed to not helps with nausea, but actually cannabis, you see this with people use it a lot and they are vomiting a lot. And in the GI or gastrointestinal journals, they write a lot about it. And once they get admitted or they stop using, then the emesis, the vomiting and all of that actually stops. And cognitive impairment, I think people are aware of it. And also it's more carcinogenic if you are smoking it, the way it burns, it's more carcinogenic. So there's the risk for cancer. It also adversely affects with, shorter gestation, preterm labor, lower birth weight of babies when used during pregnancy, and there's hormonal effects in fertility. And then I briefly talked about the new psychoactive substances. Another reason that we may not be really picking up all that's being used because of the variety of substances that are available out there. I want to shift a little bit now to move into the topic of COVID. Before we go into COVID, just to put things in context, I kind of want to think about mental. There was Lancet did a initiative, I think 2007. They had a No Health Without Mental Health, and the people who did a lot of work, elevating, the global mental health and what kind of work needed to be done. So they've made a lot of strides in time since then. This whole issue of disability adjusted life, if you look at the global burden of diseases across the world, and what happens when someone has mental illness, and this disability adjusted life years, the amount that it takes away, it's significant for people with mental illness. In fact, the person who did the whole No Health Without Mental Health initiative, he actually worked in UK. I heard a presentation when he says if two people come to the emergency room with heart disease, with chest pain, one will get admitted, get treated, will get stent or go on to bypass, and the other person with chest pain gets sent home. And he said the person who gets sent home usually is someone with mental illness. So the advocacy piece that for people to get the care that they need, that's a huge need. I think anyway that I want to talk a little bit about this, and then this slide also goes into the global seen when you think about the low-income, middle-income countries. So the blues are all, the mental disorders, neurological disorders, and then the purple is the substance use. The red is like infectious diseases, which if you look at high socioeconomic, the very first bar here, there's very little of red, which means you don't have infections. This is pre-COVID, of course. Just to put it in context, so it seems like the biggest things, even back then, the global burden was going to be with more mental health, actually musculoskeletal, chronic back pain, headache, those things are the ones which would have the biggest impact. But of course, all of this changed with COVID. And coming to COVID and the pandemic and where we are today in the middle of a very prolonged pandemic, which is going to have far-reaching effects on everyone. I can't imagine anyone who's not affected by it. I have a few slides and then we'll go into questions. So here with substance use and mental health, again, there's not a whole lot of data that's coming out globally or, what's happening across, we'll have to wait a little bit more, I think, but across the board, it seems there's existing inequalities are sort of magnified, and there's new, people who were having difficulty accessing care and having greater difficulties and those kinds of things. The increased isolation and lack of access to essential services has been a big thing, abrupt termination or interruption of treatment. People had to kind of deal with things by themselves. A big thing we are seeing with families of people with autism spectrum disorders, because and there are a lot of adults with autism spectrum disorders, and with families when there's lots of structure, everything was going well, they had care, they could go to places. When the disruption of the routines, and then even families, in those families there were people who lost jobs or other stressors, so that when the routines went away, people with mental illness or people with developmental delays and lots of other people who have really suffered the most. And then in households, we've heard a lot about increase in domestic violence, and remote care, there's pros and cons to it. And it's surprising at the level we've translated from doing in person. It's a remarkable thing that we are able to do remote care. However, not everybody has access to those, inability to use technology, there's lack of privacy to engage in appointments, people are often sitting in their cars. It is somewhat more superficial, I would say. I also want to say El Camino is one of the very few places that's continued to do in-person care, both out, throughout the pandemic. Our outpatient programs and groups have all been in person, which is a tremendous achievement in and of itself. And I do also want to recognize the remote has made it available for some people who, it's easier to get to appointments or the travel time and all of that. So there are pluses and minuses. Some people do say in remote you share more. Anyway, I won't. There's pros and cons to everything, I think. Increased substance use has happened quite a bit. At the very beginning, a lot. Just looking at the sales of alcohol, I think people were looking at that, and I think it seemed to sort of stabilize. Relapses, a lot of that happened. This is from a recent paper, and they actually say having a mental health disorder puts you at a risk for COVID-related mortality. So as the COVID is sort of still an ongoing thing with 224 million cases worldwide, they say they looked at this data from 7 countries and 3 continents, and they said the risk factor, the COVID-related mortality, was irrespective of or independent of age, COPD, cardiovascular risk. That I thought was interesting. And this paper, people talked about it a lot. It came out in April. Is the neuropsychiatric sequelae of COVID-19. In Lancet, they looked at a large group of 234,000 people diagnosed with COVID. 33.62% received a neurological psychiatric diagnosis in the following 6 months. with a many large number of people, that was the very first time they got diagnosis. It was like, it's very interesting. It's like stroke, dementia, anxiety disorder, psychotic. It's a variety of different things. Again, we see that a lot. I think either there's sort of a delirium. There might be someone who had dementia who's doing okay at home, and then they become positive for COVID. They may not have pulmonary symptoms, but they seem to be more agitated and they have more delirium. So those kinds of things seem to me related to the sort of neuropsychiatric sequelae. There's also the concept of the long haul COVID. So people had COVID and they're no longer positive, but these long-term symptoms persist. So people are talking a lot about those. And this was a New York Times article where about people languishing. The pandemic, when we think about a continuum of mental health, whether you are flourishing, that's where we all want to be, thriving and flourishing. And then there's one end with mental illness, and people with mental illness can also get to, the treatment can get to be flourishing. In the middle is a lot of people who are languishing, who are quite not gotten to, having diagnosed with depression or anxiety, but they're quite, it's sort of, I think as the article said, it's sort of a blah state, if you will. That seemed to sit right with a lot of people with the pandemic. Your life was sort of put on hold. Young people couldn't do the things, move or do the things they wanted to do. I shouldn't say young, only young people. For everyone, I think it's difficult. So if you think about what are the things we needed, this paper was actually from 2002. So it's really looking at the whole fabric on how much our social well-being, how much that integration, acceptance, and how much we feel they contribute to the community, all those things that make meaning for us to thrive. Not just the one person, how satisfied I am. It's like that interaction is a big piece of it. And that was missing for a lot of people. And that is your languishing. And if you go further, the COVID-related distress, I think the isolation, destruction of supportive relationships, the biggest stressor, probably unemployment, financial burdens, fear of getting COVID, the inability to tolerate uncertainty. I would say that everyone can relate to. I think, and we think it's going to end and it isn't. There are variants, this kind of constant uncertainty, inability to sort of make plans or decide what you can do. That's a huge stressor in and of itself. And then the barriers to treatment, stigma is another big issue. And I think people have talked a lot about the deaths of despair, and there was something that came out early last year, or May of last year, which is predicting the deaths of despair. That really is the economic failure from massive unemployment and isolation. If you think about the deaths of despair are really the suicide, the substance use, and they're really the socioeconomic factors are the biggest drivers. So we looked at depression back in the Great Depression, the financial collapse after the 2008, globally when people had that. So they've looked through different times, and that unemployment factor alone there's lots of statistical data which shows that that's the biggest, and that's how this projected increase in deaths of despair. And how do we address the challenges? Promote health literacy, address issues of vaccine hesitancy, I would say is big. Looking for accuracy of information, maintaining some normalcy of routine, making sure we can stay connected as much as possible, accessing online resources, Zoom things that we could do for our own wellness, and learning coping skills to manage our stress. Participate in community efforts to also help out, reach out to people who might be suffering more than us. Well, especially the older people who became even church organization, the things that were helping out people a lot, the elderly, live independently, those things that kind of ceased, and we've seen a lot of admissions from that. That is, I think, important to help out people who are most affected by the pandemic, and also eliminate stigma. So this next slide, I think, I think a lot has been talked about stigma. If you think about, there's the self-stigma, public stigma, structural stigma, and so many kinds of stigmas. The biggest thing I feel is being open about our struggles and talking about it. So there's no isolation, keeping it all, whatever it might be. When we when we reach out and when we talk about whatever we are experiencing, then that actually contributes to educating other people and decreasing public stigma. And we don't have to if there is public stigma about anything, we don't have to personalize it. When we kind of take it on, it becomes our self-stigma. It doesn't have to, whatever it is we are dealing with. At the end of the day, I think every human being has their challenges, one form or another. Being compassionate to each other, and also talking openly about, which I think people have, in some ways, some of the data actually says people are more open to talking with the pandemic, so there's lots of data out there. Here are some ways of coping with stress. There are some crisis numbers you can call, but basic things about, I have a few other slides on meditation, mindfulness, exercise, stretching, getting sleep, eating nutritious meals, a gratitude journal, setting healthy boundaries, radical acceptance, a routine preventive care, and then connecting with friends and family, connecting with community organizations where we feel like our life is meaningful and we reach out and help someone. I think that also provides meaning for us. There is interesting, the most popular course at the Coursera, taught, I think, at Yale by a fairly young woman on happiness. I think that's supposedly millions of people log in. Her thing is very, very simple, kind of like, being grateful. These are things, and some people say to change their lives, and other people say that's too simple. But in reality, doing all of these simple things is actually very hard. But that really is sort of the key. So here, moving on from here, I could either pause here and we could open up, or the questions that came by already, I have put together, have some responses for it already. Shall I go through the questions that I have?
You midway through your presentation.
Okay, all right. Okay, I'll go ahead and
maybe at the end we can go through the questions. That'll be great. And then everyone else, if you want to start putting your questions in the chat, that'll be great too, so that Dr. Nathan can start answering those. Thanks.
Okay. So here was a question: how has COVID isolation affected recovery, impact on alcohol, AA or NA, and other anonymous meetings? What are new challenges? AA, NA, all of they are still available through Zoom, and I'm not quite sure how they're opening up, but these were all the online support which I used to give out to people in the middle of the pandemic. They were actually offering all of this. There were some Reddit recovery, NAMI is there, and other things. So I just put together some of those, if that's helpful. I only recently learned about this recovery Dharma org, but apparently that's been going on for a very long time and has, people say it's been very helpful. This question was: our culture is very focused on meeting goals, making progress, getting ahead. What are tips to avoid striving for attaining a certain outcome during meditation? I really like that question. I have an interest in meditation, so I have 3 slides for that. So anyway, the quick answer is, the process of meditating, the art of being in the here and now, is more relevant now than ever. When there's so much uncertainty, it's like, worrying about the future or ruminating about the past. I think getting away and being in the here and now, I think kind of alleviates a lot of that anxiety. And investing in your own well-being, I think that has to come first before you take care of your family or your work environment. If you invest in taking care of yourself, promoting, and that's the best investment one can make, and it'll actually help other people as well. So this is sort of a Buddhist, I think it was from, the San Francisco Buddhist, so the 3 tenets, they talk about the not knowing, approaching life as though you don't know everything. It's kind of clearing your mind of all preset notions and beliefs, kind of keeping a fresh, open mind. Approaching most things and everything in life, if you can approach from that, not knowing is a great way, and bearing witness to the journey. So this kind of answers some other questions. I feel there's so much suffering in this world, and in psychiatry, I wish we could alleviate, take away all the things, the sickness or the trouble with housing, so many things are affecting people. But I feel it's sort of bearing witness to the journey. So it's a privilege to bear witness to someone's journey, that being present, fully present, actually bearing witness in and of itself is helpful. So I do want to say that anyone can do, or, in many different ways, we all do it, I think. If there's interest, I can talk a little bit more about it. And then the compassion, the differentiation of the empathy and compassion, I can talk a little bit. Coming back to the brain networks, there's this, your mind wandering. They found that network, there's a default mode network. Your brain kind of, when you're just sitting there and your mind is sort of wandering, there's a state, and they found actually there's a place called default mode network. Sometimes when you're depressed, you're in that sort of mode, but also it's your creative side of the brain when you're kind of daydreaming in a way. However, if you could, when your mind wanders, just noticing it wanders and bringing it back to your breath. Just taking a deep breath and letting it out, and just focusing on that breath for the time. The minute you notice your mind is wandering, bringing it back to the here and now. I think it's kind of like mind exercise. My mind wanders a lot, by the way. So anytime it wanders, rather than say, no, I should be paying better attention, you just notice and bring it back. And that in itself is a very good way to, if you can do 20 minutes of meditation every day, you could, but otherwise you are being fully present. The minute your mind wanders, you bring it back to the here and now. And the idea of genuine happiness, which we're all looking for, is the fulfillment and satisfaction based upon the quality of being that we bring into the world, rather than the pleasure that comes from getting what we can from the world. It's from, engaging with our loved ones, being fully present. It's more about who we are and not what we get. It's not stimulus driven. So this question is, I'm especially interested in those who self-medicate with marijuana and don't see a problem with that. I think I talked a lot about cannabis and the concept of self-medication. Again, I kind of want to go back to that hypercataphia, that state that people are in. It's when you have a really exhausting day, you come back, are you going to meditate for a whole hour? Or are you going to have like a glass of wine that immediately, so that's sort of a bottoms up, but the tops down, in a top down kind of approach to things. It's slower to kind of get that benefit, but actually is longer lasting. So it's kind of looking at it, and we all make those decisions, but it's one way of thinking about it. And this question was how to help someone who has not accepted his mental health issues, misuses DXM cough tablets, refuses help partially due to high functioning autism. And I think I talked a little bit about autism spectrum disorders. They're particularly suffering because of the disruption in routines. The caregivers are stressed, everybody's stressed, the disruption of care services. I don't have an easy answer. I think that's really, I think the pandemic has kind of shown where all the needs, the bigger needs are in the community. So that is a need definitely that needs to be addressed. And dextromethorphan, that's the DXM, it does cause paranoia, hallucinations, delusions, sort of the dissociative effects like ketamine and PCP. It's it can adversely affect you. This was what can you share about eating disorders in older adults, and how can we get better coverage for treating, especially with Medicare? I don't know too much about eating disorders. I wanted to talk a little bit, just talking about, when you think about all eating disorders, anorexia, there's bulimia, there's binge eating disorders, avoidant restrictive food intake disorder, which came about more recently. And they are very serious conditions and with the highest mortality rate of any mental illness. So that's a very important thing to remember. Eating disorders with older adults, I did some searches on it. It's common with dementia, so screening tests like MOCA might be important to sort of look at that. There is also there's I think there was it actually said picking, and there were sort of interesting things. And there's the binge eating disorder also with schizophrenia that could be an effective antipsychotic medications that make you more hungry. So eating, craving for food could also be related to that. So Medicare treatment should be okay. I'm not terribly sure, but I think the issue might be parity diagnosis. And often I think if they have, for example, PTSD it's not a parity diagnosis. So you have to have a diagnosis of major depressive disorder, some depression, something that's already allows you to get treated. So that might be it. But often people who have eating disorders also have, depression and other things. So that might be one way. But I'm not too familiar with that. Someone else might know more about it. Could you address the best way to connect with those with severe anxiety and depression? What are subjects that should be avoided? I kind of try to cover this in the presentation about being fully present and compassionate, being authentic, really not trying to avoid anything. And so the whole motivational, ways of, acceptance commitment therapy, we can talk more if people are interested in that. Where is all the help promised to people with the addiction and mental illness? I do want to say things are better today than, with people being more open, I think, talking about their personal struggles. Everyone's kind of experienced social isolation and effects, and there's a little bit more better understanding, more awareness, I would say. I think we need more continued advocacy, raising awareness and fighting against stigma. And I think, and this might be the, how has the COVID impacted suicide? What is the place to get trained? I think I talked a little bit about the COVID and suicide already. I guess looking at society as a whole, the individual factors, really the only prevention that can be done is means restriction. So limitation of access to lethal methods. I think some of the other countries, they've put in, carbon monoxide poisoning, they put in certain things so the gas that comes out is not so poisonous. If you have, farmers around the world, actually 80% of the suicides happen in low and middle income countries, and where people, farming and those pesticides, they are hoping to make them less toxic. So those are method. Means restriction is a good way, and guns, of course, is a big thing. So I would, and this might be the, no, actually a couple more. So we are all challenged by using online resources and Zoom as the main communications tool. How do you plan to improve that now? So we have provided in-person services, but I do want to say the online Zoom has some positive factors as well. I think I talked about that, less barriers, transportation, getting somewhere. So if people kind of figure out how to use the technology, it actually can be, it's better than missing appointments. People actually cancel less apparently now because of Zoom. This might be the last question I had. I think it says, I'm sorry. When a loved one, so they go to the, I think I'm not able to see the top of my slide, EPS or even ED, just want to, I guess the issue is when you call 911 or the police or EPS or even the emergency room, they just want to treat and release. My loved one says they want to get sober, never any follow through. Am I to leave them on the streets to die? It seems like I have to wait till GD, which is grave disability, when they can't eat or take care of their ADLs, etc. This doesn't sound right. What new out-of-the-box treatment do you suggest? That's a real challenge, and I don't have any new out-of-the-box option. I guess I would say to be respectful of the person, to preserve their dignity. I do, as I said, AA, NA, I think it's free. Anyone can go. You don't have to talk or say anything. You can just be there. So committing to 90 meetings in 90 days, getting a sponsor to make it a bigger commitment. You can't force sobriety on people. I think you can't. I think sometimes people want, hold them or longer. you really can't. I think it has to be least restricted treatment. That's just my own personal viewpoint. I don't even like an abuse because that punishes people. Already there's so much shame about. So if you give something and tell people, well, take this medicine, and then if you drink, you'll have a really bad reaction. Now that kind of thing generally doesn't, because we want people to be, not suffering or feeling bad about what is happening. So I'll stop there, I guess, and open up for other questions.
I'm gonna, yeah. Oops, can you see me? Thank you so much, Dr. Nathan. So I do see a question, some questions listed here. Let's see. So I think the first one says, please clarify individuals that have co-occurring disproportional died from their COVID symptoms.
Individuals that are co-occurring disorders disproportionately died from their COVID symptoms. So that was a paper that just came out, the 2021, the JAMA psychiatry paper. They said the severity of it, I think with just mental disorder, it said. I think when you talk about substances, I think with a lung, respiratory, if smoking or any of those things that might have put people at risk. But that whole mortality, they took all that out. That paper that was looked at 7 countries. Is that maybe what you're asking? I think that just came out in JAMA Psychiatry. I think the countries were, gosh, I'm forgetting. I think there was only one from Asia was Korea, I want to say, and it might have been continents, might have been Europe and the US, and they looked at lots of different things. The severity was, I'm guessing, so much that people don't get the medical care, maybe not going to the hospital, that access, those things might be related. The same way as people don't get the cardiac treatment that they deserve. That might be how it is happening. It's sort of more to do with access, not so much the illness itself. That might be the simple answer. The next question. Oh, yes, go ahead.
Yeah, thanks for answering that. There is a comment here. It's not a question. It just says some AA and NA are meeting in public now. Some meetings take place in parks, outdoors, at churches, etc. So just a comment here.
Yes, I think they are opening up now, and that is nice to be able to meet, and meeting in open areas where people, a lot of people around here are vaccinated and still being masked or being out in the open. I think it's a good way to get established.
Yeah. Thanks. And then if anyone else who's attending has a question, you can raise your hand and I can unmute you too. You don't have to necessarily type it here. If feel free to raise your hand, and there should be a hand sign. Anyone have any questions? Okay, I think there is another question that came in the chat right now. It says, do you think families have suffered from fears of their loved ones that have co-occurring bringing deadly virus home from their risky behaviors? It was hard enough to deal with the mental issues.
Yeah, I kind of want to say the risky behaviors kind of happened across the board. I don't want to say only people with, I think pretty much at some point people wanted to take a risk. I think didn't want to, people were tired, I think, so going out without a mask or social distancing, or people going to games or whatever it is. I don't want to say people shouldn't have done this or that. I think to some degree, everybody did something that they were, I think it's being so much under pressure, right? I think coming to work actually was, through the pandemic, I've been going, that actually, if you say, and then I always felt bad putting other people at risk. If you're going to the hospital and that was sort of risky. If you think about what is risky behavior, like frontline workers, right?
Yeah,
All the people who did. So I don't want to, it is what it is at the end of the day, that'll be I don't know whether I really answered it, but that's how it works.
It's been a hard year for everyone. It's been really difficult.
Yeah.
1.5 years still going on.
Yes. Yeah.
Another question is, have you seen an increase in patients being hospitalized at El Camino for behavioral health issues since the pandemic began?
Yes, I would say a big yes to that across the board. I think not just here or everywhere. I think the need for mental health, people wanting mental health services for the first time ever, it's gone up a lot. That's probably impacted a whole range of people. I think people going away to college for the first time, for example, and being isolated there. Just so many different, we often talk about the older people, but young people are also very significantly impacted. So I would say just people who got depressed and suicidal in the pandemic, I would say yes. That's the simple answer. There's also the other issue of people coming into the emergency room or medicine who also have other things going on, but they have a behavior, some sort of, meaning there's grief, right? There's so many people who've lost someone from COVID. So there's an impact. I think the ED, I was talking with our ED, a doctor, and I guess someone who came in and their whole family had died or something like so many people had died of COVID. It's unimaginable, the kinds of things. So that takes up also, it's affecting everyone else, I would say. And for healthcare workers, I want to say, who've been doing this for so long, they're also at burnout and, there's been a lot of that. So it's sort of stress everywhere, I would say. It's certainly we have seen a bigger,
Yeah, in fact, even at NAMI Santa Clara County, the number of calls on our warm line increased during the pandemic. Also, the length of the calls, usually people would call and we used to know what an average length of the call was, but now it was longer. Like our warm line staff was speaking for longer times because, as it is, you have these mental health issues, and then to add to that all the COVID issues, it's very hard, and not being able to meet family members and friends and regular things. So it's been a hard year. Okay, there is another question here. Is there a new method of treatment that uses cell phones to maintain their psych meds and relapse prevention?
I don't know. You mean like an app? I think there are lots of apps that are out there as a reminder that people could kind of do. Yes. Okay.
Yes.
Yeah, I think there are several people. There's a flurry of things that have come out. There are kind of coaching. There's a whole platform that kind of connects people. You could go in and then you can get the whole thing. More mental health services, but not from someone you would meet, I think, but it'll kind of match you up with someone, and they're fairly reasonably priced, it seems like. So it is there, but I guess the need is still there. I guess I would say the need is so immense. And not everything has, there's no one thing that's kind of taken off, I would say. Other than you find, a lot of the people who are seeing patients, seeing their therapists, they've never met their therapist. It's not like you were already in therapy and the COVID. I think is okay. You've met and you had a relationship and now you're just doing. But I think just actually starting, most people have started therapy and never having met this person. Some are only just doing telephone. I think that's even harder, I think.
Yeah, telephone is hard.
Yeah. Apps would be good. I think that'll be the next thing to here in the Silicon Valley. I think if people can figure out something.
That's a great idea, Dinah.
Yeah.
Any other questions? I don't see any other questions here. If you have any questions, just let me know. You can raise your hand or put in the chat. I guess not. Let me check. I think there are about 9 people watching on YouTube too, about 10 people watching on YouTube as well. So I don't see any questions there. We have a question. Will these slides be available to view later?
Yeah, I'm happy to share. In fact, I sent it, you're welcome to send it out.
Perfect. So I'll send it out tomorrow. And you can also always watch this recording on our YouTube channel. It's NAMI Santa Clara County. So yeah, this is live right now, so it'll stay on YouTube. So anytime you want to go back to this PowerPoint presentation, you can always look at it again. So I guess that's it. And thank you so much, Dr. Kalpana Nathan, for speaking at a general meeting tonight. I think this information was very, very helpful, and it's a very, very important topic to discuss. Thank you for your PowerPoint presentation and spending your evening with us. So from everyone here at NAMI family, we are really, really grateful for you coming in here today.
Okay, thank you so much.
Thank you. Thank you, everyone, for joining us tonight, and we'll see you next month. Bye-bye.
Bye.